In this video, we're going to go over diabetes medications. All right, so starting with some normal pathophysiology, we'll start with low blood glucose. The pancreatic alpha cells detect the drop in blood sugar, stimulate glucagon to be released. The liver becomes stimulated to cause glycogenolysis, which is the conversion of glycogen into glucose. And then that glucose is released into the bloodstream in order to allow the blood glucose to increase. With high blood glucose, the pancreatic beta cells detect the rise in blood sugar. Insulin gets released. Insulin then goes and binds to insulin receptors. GLUT4 is used to translocate the glucose to the cells, and then the glucose is able to enter the cells for use. Glucose can be used for multiple different things depending on which cells it is brought to. So, in muscle tissue, it's used for energy use and glycogen storage. In adipose tissue, it's used to convert glucose to triglycerides. In the liver, it's used for glycogen storage and to decrease gluconeogenesis. And all of these work in order to decrease blood glucose. All right, now type 2 diabetes pathophysiology. Chronic metabolic stress, such as obesity, inflammation, or genetics, causes insulin resistance to develop in peripheral tissues. So, blood glucose is increased after eating. This causes the secretion of insulin from the beta cells. Insulin travels and binds to the receptors. And this is typically where a GLUT4 would take that glucose and take it to the cells in order for use, but post receptor signaling is impaired. Therefore, translocation by GLUT4 is minimized. Glucose is unable to enter into the cell and it remains in the bloodstream, which causes hyperglycemia. Now, with type 2 diabetes, the longer that this goes on for, the more damage that is being done. This can eventually lead to progressive beta cell dysfunction, a decrease in insulin secretion, or worsening hyperglycemia. Okay, now let's go over some treatment recommendations. This is something you're definitely going to have to know in your primary care courses, but it's good to know in your pharmacology course as well because you may have questions on your exam as far as when you are supposed to treat a patient and which is going to be the best option for that patient. Now, these treatment recommendations are based off the 2026 American Diabetes Association guidelines. So, starting with diagnosis, a pre-diabetes diagnosis is a hemoglobin A1C between 5.7 and 6.4. The recommendation for this is lifestyle modifications for all. And then you would want to treat high risk patients who are aged 25 to 59 years old with a BMI of 35 or greater, a higher fasting plasma glucose greater than or equal to 110, and an A1C greater than or equal to 6, and then any individuals with prior gestational diabetes. A true diabetes diagnosis is a hemoglobin A1C of 6.5 or greater. The recommendation for this would be to treat. All right, so in this other box, we have some drug choices that are good for certain comorbidities that you need to know. So if you're aiming for glycemic control only, first line typically is going to be metformin. If you have a patient who you're treating for diabetes who also has ASCVD or is high risk for cardiovascular disease, two good choices would be an SGLT2 inhibitor with CVD benefit or a GLP-1 with CVD benefit. For patients with heart failure, an SGLT2 inhibitor with a heart failure benefit would be a good choice for them. For patients with chronic kidney disease, an SGLT2 inhibitor with chronic kidney disease benefit or a GLP-1 with chronic kidney disease benefit. And then for weight management, a GLP-1 is going to be a really good choice. Now, whenever we're talking about management for patients with diabetes, specifically type 2 diabetes, we're going to be talking about in this PowerPoint because type 1 diabetes is going to be managed mostly by endocrinology. So, for treating patients with type 2 diabetes, we're typically going to start with a first line medication, very commonly metformin. But like I said, if they have certain comorbidities, we might choose something else in this chart. But we also need to keep in mind that for patients who have uncontrolled diabetes, specifically patients who have an A1C of greater than or equal to 9, it is recommended to begin basal insulin. Now, this is regardless of if they have tried other medications at that time. If they come into your office for the very first time, they haven't been seen by a doctor in 20 years and they come back and their A1C is 9.5. The recommendation is going to be to start them on some sort of oral medication or injectable medication, such as metformin or a GLP-1 or an SGLT2, depending on the patient specifically. But it's also going to be recommended to go ahead and start basal insulin for that patient. So at any point that a patient has a hemoglobin A1C of greater than or equal to 9, it is recommended to start basal insulin. Typically, we start with 10 units of a long acting insulin at bedtime. And what we tell our patients to do is increase this by 2 units every 3 days until glycemic control is reached. And typically, we'll tell them that their goal is going to be somewhere between 80 and 130. And that is a fasting plasma glucose that should be taken first thing in the morning. Okay, so let's go into the treatment algorithm, which we kind of just talked about, but we'll dig a little bit deeper into it. So, when we're talking about diabetes, we know that that is a hemoglobin A1C greater than 6.5. Our target A1C is going to be less than 7 because 7 and above is considered uncontrolled diabetes. And of course, we want to keep them in the controlled category. So, patient comes in, they just got diagnosed diabetic. You're going to start with a first line agent based off their comorbidities. For exam purposes, a lot of times it's going to be metformin. But if they're talking about specific comorbidities like heart failure or being overweight or obese, some of those other situations like the SGLT2s or the GLP-1s could be a good option to start with for those patients. It doesn't have to be metformin. So you place them on a first line therapy. They come back after a while, their A1C is still greater than 7. Now we're going to add a second anti-diabetic agent. They're on that medication for a little while, they return to the clinic, and their A1C is still greater than 7 on 2 of those anti-diabetic agents. Now we're going to add a third anti-diabetic agent. They're on this medication for a little while as well. If they come back after this and their A1C is still greater than 7, then we would initiate insulin at that time. Now, don't forget what I mentioned before. At any point during this algorithm, if the hemoglobin A1C is greater than equal to 9, then basal insulin should be started at that time. All right, we're going to start with a very common medication you are absolutely going to see. This is a biguanide medication known as metformin. So this is used for type 2 diabetes prevention or treatment, and it's sometimes used for PCOS as well because PCOS involves insulin resistance. This medication works by decreasing glucose production in the liver and the kidneys. It decreases insulin resistance and increases the uptake of glucose in muscle and adipose tissue. Metformin is pretty well tolerated. Most common side effects are going to be nausea, vomiting, and diarrhea, and it can also cause B12 deficiency. It does have a black box warning for lactic acidosis, and this is more likely to occur in patients who have renal or hepatic impairment or who have excessive alcohol intake. Now, for B12 deficiency, it does decrease the absorption of B12 in the GI, but not typically enough to cause anemia. So it might be something that you want to keep an eye on, but not something to be super concerned about. One of the nice things about metformin is that it has no hypoglycemia risk. This medication is safe for pregnancy and breastfeeding. However, guidelines show that insulin is preferred in pregnancy, so it's going to be a little bit subjective to the OB provider. There are renal dosage adjustments required, and it should be avoided in severe renal impairment. Something we want to talk to our patients about is called sick day protocol. Now, this is when they temporarily discontinue metformin when they have an acute illness that may cause dehydration and restart the medications when able to tolerate fluids efficiently. So, if they are having excessive vomiting or diarrhea, or they are unable to tolerate fluids at that time and they become dehydrated, it puts them at an increased risk for developing DKA, which we obviously do not want. So, during that time period, we'll have them discontinue the medication and then restart the medication whenever they are able to tolerate fluids efficiently. As mentioned before, we'll monitor their B12 levels, although it's not super concerning that they'll develop a macrocytic anemia based off this. Something important that you need to know is that this medication should be held before IV contrast. Contrast can increase the risk of metformin toxicity, and then it's not recommended for severe renal or hepatic impairment or excessive alcohol intake because all of those can increase the risk of lactic acidosis. All right, moving on to sulfonylureas. These are glyphoside, glyburide, and glympuride. These are used for type 2 diabetes treatment. They work by binding to the SIR1 receptors on beta cells. SIR1 receptors help regulate ATP sensitive potassium channels and controlling insulin release. So, by binding to this, it increases insulin release. One side effect you absolutely have to know about sulfonylureas that's a little bit more common for this than any other oral diabetes medication that we're going to talk about is that this one can cause hypoglycemia. Something that you absolutely have to know about sulfonylureas are that they can cause hypoglycemia. This is super important to keep in mind and knowing that we need to probably avoid this in patients who are elderly or who are on other hypoglycemic agents. Other side effects of this medication include weight gain, a disulfiram-like reaction, hepatitis, and hemolytic anemia. This would not be considered a first choice in pregnancy, but may be used if necessary, and risk versus benefit should be used for breastfeeding. Both renal and hepatic dosage adjustments are required. We would want to educate patients to take this 30 minutes before meals. And then for safety reasons, we would not want to prescribe this in elderly due to hypoglycemia risk. It is contraindicated for severe renal and hepatic disease and for patients with a sulfa allergy. Glyburide specifically is contraindicated for chronic kidney disease, and this should not be combined with other hypoglycemic drugs, such as other anti-diabetic agents, amiodarone, androgens, beta blockers, and some antidepressants, and some sulfa antibiotics. All right, so let's move on to the GLP-1 receptor agonist. These are super, super common and popular medications. I'm sure every single one of you have heard about by now. They are really effective at treating type 2 diabetes as well as with weight loss. So these are great options for your patients who are overweight or obese. So these are your TIDE medications: liraglutide, semaglutide, and tirzepatide. Tirzepatide is actually a GLP-1 and GIP. So they work by using GLP-1, which is an incretin. Incretins are hormones released by the gut after eating carbs or fat to stimulate insulin secretion. So by binding to the GLP-1 receptors, it stimulates insulin secretion from beta cells and stops glucagon secretion from the alpha cells. And it also helps by delaying gastric emptying. That's a big factor for weight loss because if everything is moving through the GI system slower, it means that the patient is going to feel fuller for longer and going to be eating less calories and therefore aiding in weight loss. These are pretty commonly tolerated. Most common side effects are going to be nausea and vomiting, especially with dosage increases, constipation, because everything, like I said, is moving slower through the GI system, weight loss, pancreatitis, gallstones, thrombocytopenia, or an acute kidney injury. These do have a black box warning for thyroid C-cell tumors found in rodent testing. So to my knowledge, there has been no find of this in humans. However, there was find of this in some animal studies. So what we do for this is we avoid these medications in patients who have a family history of these thyroid tumors. These are relatively new, so there's not enough data currently on whether or not they are safe for pregnancy or breastfeeding. There are no renal or hepatic dosage adjustments required. Most of these are going to be injected one time per week. However, semaglutide is also oral. We want to educate patients to make sure that they are still eating. So patients will have a major decrease in appetite whenever they are on these medications and can go hours, if not a whole day, without eating, which is definitely not the intended use of this medication. We want them to be eating. We just want them to be making healthier choices and using this as a tool to do so. And we want to make sure that they are prioritizing protein and fiber. As mentioned before, because of that black box warning, this is not for patients who have a personal family history of medullary thyroid tumors, and this is commonly tested, so make sure that's something that you remember. This is also not for patients who have a personal history of pancreatitis, end-stage renal disease, or GI motility disorders. All right, moving on to SGLT2 inhibitors. These are the gliflozin medications. They are used for type 2 diabetes treatment, and they're a great choice for patients with either heart failure or chronic kidney disease. So that's commonly tested because these are a really great choice for a certain comorbidity, and I bet you would be likely to see a question similar to this on your exam. So SGLT2 aids in reabsorbing glucose in the proximal tubule of the kidneys. So by binding to the receptor sites, this prevents SGLT2 from working, causing glucose to be excreted in the urine rather than absorbed. So one of the most common side effects is you're definitely going to have to remember this is yeast infections and then also UTI. So this medication works by excreting glucose in the urine. Remember, yeast loves sugar. So if there is a ton of glucose being excreted down in the genital tract, yeast can be attached to that, causing yeast infections. Other side effects include hypotension and DKA. This is another one of those where there's just not quite enough data yet to tell whether or not it's safe for pregnancy or breastfeeding. It does require a renal dosage adjustment. Things we want to teach our patients about are to expect an increase in urination, keeping the area clean and dry, and reporting itching and discharge to prevent yeast infections, and then hydrating well. And then our safety notes are that it is not used for severe renal impairment or chronic UTIs. All right, moving on to our DPP-4 inhibitors or our gliptin medications. These are used for type 2 diabetes treatment. They work because DPP-4 is responsible for breaking down incretin hormones like GLP-1 and GIP. So, by binding to the receptor, this prevents the breakdown of incretin hormones and allows for an increase in insulin secretion and a decrease in glucagon. Common side effects include nasopharyngitis, headache, joint pain, pancreatitis, and heart failure, most commonly in saxagliptin specifically. There's not enough data currently to show whether or not it is safe for pregnancy or breastfeeding. It does require a renal dosage adjustment. And then saxagliptin is one that is a CYP3A4 drug, so grapefruit should be avoided when taking that medication. For our safety notes, these should not be used for patients with a history of pancreatitis or heart failure. They should not be used for patients with severe renal or hepatic impairment, and they can increase toxicity risk of ACE inhibitors and digoxin. So, unlike our SGLT2 inhibitors, which are good for heart failure, this one is going to be more likely to induce heart failure, especially saxagliptin. So, we'd want to avoid that in these patients. All right, so next, moving on to the thioridinediones, also known as TZDs. These are your glitazone medications. These are used for type 2 diabetes treatment, but pioglitazone also has some benefit for NASH. These work by activating peroxisome proliferator activating receptors, or PPARs. The PPARs aid in regulating insulin resistance and glucose metabolism. So, by activating the PPARs, insulin sensitivity is increased and glucose uptake is increased. Common side effects include weight gain, fluid retention, hepatotoxicity, bone fractures, specifically in women, and then there's an increased risk of bladder cancer, specifically with pioglitazone. These also have a black box warning that they may cause or worsen heart failure. So, this is another one of those medications that we would want to avoid for patients who have heart failure. Remember, heart failure patients, a good choice for them would be an SGLT2 inhibitor, not a DPP4 and not a TZD. These are considered to be not safe in pregnancy and breastfeeding. A hepatic dosage adjustment is required. Things we want to educate our patients on is that it may take 4 to 6 weeks before we really start seeing of some effect of this medication. And then this one is a CYP450 drug, so we would expect some drug interactions. So safety, this is not going to be safe for patients who are a class 3 or 4 heart failure, have liver disease or bladder cancer because of that increased risk. There's an increased risk of fluid retention when combined with the medication pregabalin, so keeping that in mind. And then there's an increased risk of ischemia with vasodilators and insulin. All right, so that is most of our type 2 diabetes treatment medications. Now we're just going to go over some insulins. So these are going to be more common in type 1 diabetes, but like I said, we definitely see patients with type 2 diabetes who go on basal insulin, and then there's even people who go on prandial insulin eventually. Test tip reminder, if you have a patient who has a hemoglobin A1C greater than or equal to 9, or if multiple therapies have not been sufficient, then basal insulin is recommended. All right, so we're going to talk about the insulins. We're going to talk about how quickly they onset, their peak duration, and when to take. So the onset refers to the time from drug administration until the beginning of a measurable or clinically meaningful event. The peak refers to when the drug reaches its maximum therapeutic effect. The duration is the total length of time the drug remains a clinically significant in the body. So rapid acting insulin onsets within 5 to 15 minutes, peaks within 30 to 90 minutes, and then its duration is 2 to 4 hours. Therefore, this should be taken right before meals to make sure that they are not going to bottom out because their insulin kicked in so quickly. Short acting onset is when 30 to 60 minutes, peak 2 to 4 hours, and duration 6 to 8 hours. This is commonly taken 30 minutes before meals. Intermittent acting insulin onsets within 1 to 2 hours, peaks within 4 to 6, and its duration is about 12 to 18 hours. This is done typically 1 to 2 times per day, depending on the patient. And then long acting insulin, also known as basal insulin, typically we use at nighttime for those patients who we are starting on insulin who have that hemoglobin A1C greater than or equal to 9. Has an onset of 2 hours. It does not have a peak, and its duration lasts for up to 24 hours. This is done once per day, typically at bedtime. All right, that is everything for our medications. So let's move on to a patient case. So, a 59-year-old female presents for a follow up of type 2 diabetes. She currently takes metformin 100 milligrams twice per day. She reports increased fatigue, mild shortness of breath with exertion. Her medical history includes type 2 diabetes for the last 8 years, heart failure, reduced ejection fraction with an EF of 35%, and hypertension. She currently takes metformin, carvedilol, lisinopril, and furosemide. Her vitals are 124/78 for her blood pressure, and her BMI is 33. Her labs today are a hemoglobin A1C of 8.4. Her EGFR is 62, and her BNP is elevated. Which of the following is the best next medication to improve glycemic control and provide benefit for her comorbidity? All right, so let's break it down, right? So she currently has type 2 diabetes. She's already on metformin, 1 gram twice per day. She also has heart failure with reduced ejection fraction. So, right there, you should start thinking there are two medications that are really bad for heart failure, and there's one medication that's really good for heart failure. So, we need to think about that. Her blood pressure today looks fine. Her BMI is elevated. Her A1C is 8.4, so she is still uncontrolled. However, she is under 9 and she's only on one type of medication right now. So, insulin doesn't necessarily need to be started yet. And her BNP is elevated, which is expected with a patient with heart failure. So, whenever we're thinking about which medication is going to be next, we're really focusing on that heart failure perspective of this. So, remember that SGLT2 inhibitors are great for heart failure, DPP4s are not recommended, and TZDs are contraindicated because of that black box warning. So, realistically, our next best option is going to be an SGLT2 inhibitor to help with that heart failure. And that would be answer D. So, this just kind of breaks that down again. SGLT2 inhibitors are a great choice for patients with heart failure. Pioglitazone is contraindicated in heart failure. Sulfonylureas provide no additional benefits to the patient's comorbidity. Same thing with DPP4s. In addition, DPP4s have a potential increase of heart failure, especially saxagliptin. And then insulin is not necessarily indicated yet. So, answer D, the SGLT2 inhibitor would be the best option for this patient. All right. And then here is that key takeaway chart if you want to pause and write everything down from there. I hope this cleared everything up and made diabetes medications a little simpler.